Good afternoon, good morning. I'm Donna McKay, the Executive Director of Physicians for Human Rights, PHR. I want to thank you for joining us today for another important conversation in PHR's webinar series on the health and human rights implications of the COVID-19 pandemic. Today, I am thrilled to welcome our incredibly esteemed panel of experts who have each singularly and significantly influenced the world's response to and research of the HIV/AIDS virus. Like the HIV/AIDS epidemic, the COVID-19 pandemic has exposed systemic inequalities. And while inequalities in health are certainly not new, the COVID-19 pandemic really has laid them starkly bare. And we've witnessed the same inequalities play a debilitating role in the treatment and responses to HIV and AIDS. We have hundreds of you live with us today to listen to our panel of experts discuss the lessons we've learned from the HIV/AIDS epidemic and how we can use these to inform our response today to the COVID-19 pandemic and those in the future. So I'm thrilled and honored to welcome back today's moderator, Dr. Chris Beyrer. As someone who has built a momentous career dedicated to health and human rights, we're so fortunate to have his participation today and expert guidance overall as a member of PHR's Advisory Council. Chris is the Desmond M. Tutu Professor of Public Health and Human Rights and Professor of Epidemiology, International Health, Behavior and Society, Nursing and Medicine at the Johns Hopkins Bloomberg School of Public Health. He's the director of the Johns Hopkins HIV Epidemiology and Prevention Science Training Program. Chris is a past president of the International AIDS Society and was elected to membership of the National Academy of Medicine. Without question, Chris has emerged as one of the most influential leaders during the COVID-19 pandemic as a scientist and as a researcher. And he's been serving in the critical role of senior scientific liaison to the COVID-19 Prevention Network established by the National Institute of Allergy and Infectious Diseases. So Chris, I want to thank you so much for joining us once again today to bring your insights and to lead this very timely and important conversation. And I turn it over to you.
Well, thank you so much, Donna. Wonderful to be with you and wonderful to be with our remarkable panelists for today's discussion. Welcome everybody listening, and please do engage. You'll have the ability to ask questions of our really wonderful group of colleagues and friends here. And we really would like this to be as engaged and interactive as we can. Just before we begin, I want to just say a few things, and I think we have to begin by acknowledging really the extraordinary loss of human life that has occurred with this pandemic. We are approaching 3 million fellow human beings, brothers and sisters, mothers and children, spouses who have passed. Probably we're over 3 million if we had better surveillance in many countries. And in my country, the United States, this morning we've passed 564,000 dead. Which is just really an extraordinary toll. It is continuing, of course. We are not out of this pandemic yet, although the science has been spectacular. And once again, the investments we've made in science have really shown us the possibility, we hope, of achieving pandemic control and of improving treatments for people who have COVID. But nevertheless, all of those losses, of course, amount to tragedies for individual persons, families, communities, and we really, I think, need to acknowledge how much loss and suffering this virus has cost humanity. I want to just say, by way of beginning, that I think all of us who come from an HIV background, and as I introduce each of our panelists, will just recall their extraordinary leadership. These are all people who have contributed for decades to the HIV response, both in their countries and globally. That it was remarkable how quickly the health disparities that we have all been dealing with in HIV for decades reemerged with COVID with remarkable speed. In the United States, it was very clear by April and May that there were both higher rates of disease acquisition, higher rates of hospitalization, and higher rates of mortality, death from COVID among African Americans, among Latinx Americans, among our Alaskan Native and American Indian populations, of course, among the elderly, and people in congregate housing, but also in our prisons, jails, and detention centers. Extraordinary disproportionate burdens. And as so often has happened with pandemics, and certainly happened with the HIV/AIDS pandemic, these kinds of outbreaks that affect us all don't do so equally. And so often reveal the fault lines in societies, the challenges in societies. So it's easy to say, for example, that everywhere we look, there have been prison outbreaks with COVID. Yes, but it's also the case that what that reveals again for us in the United States is our huge social problem of mass incarceration, that we incarcerate more of our citizens than any other country. And so when you say that there's a disproportionate burden of people in carceral settings, you also have to say, and that's a huge problem for us as Americans, because we have all kinds of people in prisons and jails for unpaid fees and fines, for what really would be misdemeanors, for issues related to the parole system, possession, solicitation, all kinds of crimes, or if you even call them crimes, all kinds of challenges, where you would ask yourself, is it right to put somebody in a prison setting or a jail setting where they might be exposed to this deadly virus for an unpaid fee or a fine? And then you ask yourself, is it ever right to do that? And pandemics really expose those fault lines. And I think they have done so in many, many countries for many different kinds of populations, also refugees, the displaced. Of course, in South Africa, as we'll hear from Salim, enormous health disparities pre-existed with HIV, with tuberculosis, with a range of conditions, but once again, health disparities emerging so starkly with COVID-19. So I think one of the many lessons that we have learned, one of the great lessons that we have learned from HIV is what people would call the San Francisco model, right? The San Francisco model, which both Eric Goosby and Diane Havlir have been very much a part of, has been moving forward, and Diane has been a co-chair of the committee doing this to really try and get control of HIV. And to do that, it requires partnerships between communities, affected communities, the research enterprise, the clinical enterprise, and also public health and government. And I think that multilateral partnership and the real commitment to leaving no one behind has been so fundamental to the success of San Francisco. So for that reason, we're really thrilled to have Diane Havlir with us, a dear friend and colleague, a former IAS Governing Council member, the chair of the International AIDS Conference in 2012, when we brought the conference back to the US after Barack Obama made an important human rights move and lifted the long-standing sanction on HIV-infected people traveling to the United States. So Diane is a professor of medicine, and she's chief of the division of HIV, infectious diseases, and global medicine at the University of California, San Francisco. She is the co-chair of the WHO Treatment and Prevention Global Guidelines Committee. She's the chair of the UNAIDS Scientific and Technical Advisory Committee, so playing, of course, international roles. Co-founder and co-chair of San Francisco's Getting to Zero, the campaign I was referring to. And she established, in response to COVID with colleagues in San Francisco, Unidos en Salud, United in Health, which was really a program to try and address the enormous health disparity that emerged with Latinx Americans, particularly across the country, but also very much in California and in the Bay Area. So Diane, I'd love to start with you if we could, and start with San Francisco, where you have made such contributions. And just tell us about the lessons learned from the response to HIV in how you tried to tackle the health disparity that emerged so quickly with COVID.
Thanks, Chris, and it's really great to be here. You know, no one's really ever ready for a new pandemic, and we all know through history that with new pandemics come fear, misinformation, and conspiracy theories. We've all been through this before. And also with most pandemics, we first see them, the the most dramatic clinical manifestations in the hospital. That was the same with AIDS. And that really was the same in COVID in San Francisco, where, normally in our hospital, San Francisco General serves the public, there's about 20 to 30% of our patients who are Latinx. All of a sudden, COVID, that number jumped to 85%. And that was just a complete wake-up call. And our hospital is located right in a predominantly Latinx neighborhood in San Francisco. So immediately we are thinking, absolutely, we need to understand how to take care of patients in the hospital. But all the action, all the transmission right now is happening in the community. And we need to understand that better. And really one of the most challenging things about SARS-CoV-2, as we know, it's not like SARS, and asymptomatic transmission is a huge underpinning of this pandemic. And, had we to do it over again, I think we would have acted probably as a society a little bit differently about that. So here we know that a community is being disproportionately affected. It's in our own backyard. So what does an HIV person do? We call our go-to HIV people that we work through with years. This is social networks. This is what we do. So I called one of my colleagues, Diane Jones. I reached out to Grant Colfax, as you know, who's in the Obama administration, heads our health department, connected with a community group, an amazing community group in San Francisco, the Latino Task Force, and said, we're concerned about this. They said, we are too. We're already giving out food. We know about this effect on our community. Let's work together. And I have to say, like, some of the principles that we have learned and continue to learn, it's not about community outreach. It's about respectful partnerships. People have expertise. Outreach communication is best done from community to community members. I feel like our job as physicians is to generate data, convey data, and have people who can best speak to the community speak to the community. So and also, it's not only about what we do, it's about the how we do it. There is no one size fits all. We've learned this in HIV. And also, and I think this really happened all around the world from the get-go, just to let people know, information is going to be coming in and constantly changing. This was like fast forward compared to the HIV epidemic, how much we were learning, because people think once we say something with confidence, we're not going to say something that contradicts it. We all know in science, we say things because we have to act, we have hypotheses and things evolve. And I think if people know upfront, that is what we're going into, that is very, very helpful. So in San Francisco, we really focused on the concept of low barrier access to testing to understand the epidemiology of the disease and what was happening with transmission. So when everyone was told to do shelter in place, we asked everybody out in a very systematic way to come out of your house and get tested, and generated the data that showed that the Latinx community was 20-fold more likely to be infected in the census tracts where that we were studying. And then we looked at all the risk factors, and we need to take away the stigma. It's not because a person is Latinx, it's because the Latinx persons living in these areas are not people that can stay at home and work on their computer. They are people who are working at restaurants. They are individuals who live in crowded housings because they're just trying to make ends meet. And they are individuals who really fear any kind of formalized infrastructure, including hospitals, including the public health department, including UCSF. And those are all themes that we know have been in the past. But our Latino task force leaders, also this risk having more stigma put on the Latinx community, like don't go there, because you're going to get COVID infected. But what they said was so beautiful. They said, look, our community needs data so we can get resources to help solve the problem. And that was such important messaging for us to make, for them to say to the community. And Chris, so we designed low barrier testing and now vaccine work, but just the principles of that is you don't have to go on a computer to sign up. You can just walk up, you can talk to a human being. There's going to be somebody that looks like you, that talks your language, is going to bring you in and allow you to get tested with no questions asked, with no ID, to give you the information to empower you. for some communities, that is the way. We need large mass testing and vaccine sites, but that doesn't work for some communities. So those are really some of the underlying things we did, which truly brought forth what we had learned in HIV. And I really resonated with me what you just said about all these reasons why the Latinx community was being disproportionately affected. Really, were just highlighting these structural barriers and disparities and problems in the US health system that have yet to be addressed, but we've got to be optimistic. Here is another opportunity to move things forward.
Well, thank you, Diane. That's beautifully said. And I would just reiterate for me that one of the things that was so striking being a part of the vaccine effort was the spectacular outcomes of the science and the investments that we have made over decades in basic science and molecular biology, NIH funding, and then the disinvestment of 20 years in public health, leaving us without a platform in so many places to deliver these life-saving interventions. And you know that is really something I hope that we come out of this post-pandemic period when we get to it with a rethink about our priorities and about a reinvestment in public health. And I think that flows very naturally into introducing Eric Goosby, a friend and mentor, a leader in the HIV field, and of course serving on President Biden's transition and now in the administration on the COVID-19 task force. Eric is also from UCSF. He's a distinguished professor. He directs the Center for Global Health Delivery, Diplomacy, and Economics at the Institute for Global Health at University of California. He has a deep and long history in health disparities as the founder of the Ryan White program, which many people will know provided really essential services for Americans living with HIV in the early tough years, 1991, before therapy. And then he served as the US Global Coordinator for PEPFAR. So we really must introduce him as Ambassador Goosby, and served with distinction there, and then has been appointed as a special envoy to the UN for TB in 2015, and has been, as I said, a member of President Biden's COVID Advisory Task Force. He's on the board of IAVI, so also working on HIV vaccines. He's a member of the National Academy of Medicine, Council on Foreign Relations, the NIH Advisory Board, the Clinton Foundation, and on boards for UNAIDS, WHO, and many others. So Eric, it's wonderful to have you. And I wonder if we could come out of the Bay Area and look more broadly at the United States. Few people know more and have thought more about how we have to address health disparities and think of access to health care as a human right. And I wonder if you could speak to what you feel that we have learned from our HIV response in the States for the COVID response nationally, and in particular, this issue of health disparities.
Well, thanks, Chris. Diane and Salim, it's always an honor to be on any panel with all of you. I think this is a pertinent topic that has, as HIV did, bubbled up in each country with suddenly mostly inpatient service sites being the first portal of entry. And we saw that pattern with COVID. I think the initial decision to not concretize a central planning process at the national level in the United States created 50 different attempts to develop a plan. So planning, and also created at least 50 different attempts to implement. Each of those states has large municipalities and counties that launch their own planning and implementation efforts. That lack of clarity on guardrails on what to do, where to do it, who to do it with, norms and practices not being generalized to large populations or regions, let alone the whole country, launched us into a a multiple conversations that became competitive with one another around PPE acquisition, as well as understanding how to prioritize and position your public health response to understand, as Diane just outlined, the differences in how the virus moves through the population demands that the response to that movement accommodate those differences to position our programmatic response in front of that wave. That requires a dialogue that is more intense than is generally engaged with, and in the United States is burdened by a dominance of private third-party payer programming that is taking care of most of our population, and puts us in a position where the third-party payer in the beginning of the outbreak for COVID was looked to coordinate and work with public health facilities, departments of health at state and local levels. But their initial response did not incorporate a self-expectation that they were responsible for a public health orchestration. It took weeks to have each of the third-party payers realize that they indeed did have a role in this response, and became engaged in conversations that took them in and out of a public orchestration back into just their silo for their particular patient population. As people have said, it highlighted the disparities in issues of access, in issues of retention, in our ability to diagnose and treat diseases that we for 50 years have known how to diagnose, treat, and cure, and highlights those inequities in access and retention that we have seen since the beginning of medical care in the United States, but most recently, as we've moved into managed care third-party payers, I think we've seen a distancing in the ownership of moving on public health lines for any given population, and reminds us that our ability to bring people into care and retain them requires the, I think, special understanding of specific populations to reveal what the specifics are of those barriers to access and retention. COVID showed us that in spades at every level: national, state, coordination amongst counties within each state, and then attempts in regions in the Bay Area to engage in kind of all 6 counties that touch the Bay to try to harmonize opening and closing considerations, as well as strategies for case finding and contact tracing. So I think that when you then click into international challenges, although they reflect the same types of issues, the emphasis on different aspects of the ability to identify, enter, retain people in relationships that eventually allow for a rapid deployment of vaccination strategies becomes a continuing challenge that is not fixed with one year effort, but is something that we need to incorporate into the way we deliver healthcare and bring people in to healthcare. So I think the challenge that has been put in front of us is the core challenge of the need to understand that our system was broken in the United States. It fell short of what it could have done, and did not really gather a recovery mechanism until the administration changed. And I just think that it is that clear to us as we went into a transition dialogue with the Trump administration that many of what we thought were decisions that had been made were really decisions of omission and not proactive, we're going down this pathway, but silence and then people filling the vacuum. And it took us weeks to get clear on how and where to reinvigorate those local discussions, which really are where the response must, come from. So, so I'll stop with that, Chris.
Well, thank you, Eric. And I think you mentioned lost weeks several times in your comments. And of course, I think one of the lessons we learned from this extraordinarily infectious pathogen is that time matters so much, and you never get back the early weeks in a pandemic. You really don't. Let's turn then to Professor Salim Abdul Karim, known to many of us in our community as Slim Karim, a distinguished leader in HIV who heads up one of the most productive international scientific partnerships there is, the CAPRISA program in South Africa. Slim is also appointed, he is a Vice Rector of Research at the University of KZN, KwaZulu-Natal, and also has appointments at Columbia University, at the Mailman School, at Harvard, and at Cornell Weill. So he's very much a part of the American research enterprise as well. Salim has played an extraordinary role in his country's response. He has been the chair of the South African Ministerial Advisory Committee on COVID-19. He's also a member of the Africa Task Force on Coronavirus, so serving a continental role, and now is on the new Lancet Commission on COVID-19. He's also on the Scientific Advisory Board for Global Health at the Gates Foundation, a role he's played now for a number of years. He's a fellow of the Royal Society of Medicine. Can't think of a better person to tell us about South Africa's challenges and also South Africa's rather extraordinary response. And I think an area where, as both Diane and Eric have pointed out, the partnerships, the collaborations between community, government, and science really coming together in quite extraordinary ways, but also having to deal with what is certainly one of Africa's most advanced and impressive healthcare systems that nevertheless has extraordinary health disparities, a long historical legacy of discrimination in healthcare that is unfortunately shared with the United States in many ways, and disparities again that emerged quickly with COVID. So Slim, we'd love to hear from you. You have played a leading role as the scientific voice for South Africa's response, and of course have been such a great leader in HIV for decades now.
Thank you very much, Chris. It's let me start with my heartfelt thanks to Physicians for Human Rights for hosting this really exciting and important discussion. I'm deeply honored to be with you and Diane and Eric in this session. As we think about the COVID-19 pandemic, I think there were three things that really took us by surprise. The first, which has already been alluded to, is the pace at which the epidemic moves. Mm-hmm. And when I reflect back to the calculations done in the UK, that Neil Ferguson showed that if the UK had locked down just 1 week earlier, they would have halved the deaths in April. Mm. I mean, that just tells you 1 week is a lifetime almost in this pandemic. So I think we've come to understand that. But with that kind of pace, one has to have the resources to rise to that. Yeah. If you are an individual who has a manual labor position, who doesn't have the resilience, the ability to just pivot on a short notice, this epidemic hits you. You're not the one being proactive and going to it. The second is that we learned the importance of the way in which health systems interact with people. Mm-hmm. Because when the surge comes and the thousands of patients need medical care, and they need it right now, and they need oxygen right now, there is a need to really understand the differences that go with access to that care. Now, in South Africa, in one example, we have a huge program of a huge initiative on oxygen supply, and we have oxygen is made in the private sector. Now, the four big companies that make oxygen, supply oxygen, about half of all the oxygen goes to non-medical needs. They are for commercial processes. So we met with those four companies and negotiated with them that during the surge, they will direct all oxygen to medical requirements, and that they had to negotiate with their customers that they won't be getting oxygen during those months. And that's how we never ran out of oxygen. We had a situation where our appliance manufacturer, the one that makes microwaves and stoves and so on, pivoted and started making ventilators. In fact, we have about 20,000 ventilators that they made, not just ventilators, but also CPAP machines and so on, so that we were able to rise to those occasions because we were not prepared for this. I don't think anyone was. And so you had to be able to mobilize the resources, because the moment you don't have those, the inequities in the system become really sharp. Yeah. And then, in only those few who can afford will get access. So that was quite important. And the third point I want to make is that I think for me, having played the role of chief COVID scientist in South Africa, I began to understand the central importance of our mutual interdependence. That, and when I dealt with HIV, and, I've had the pleasure of showing Eric around my clinic and just dealing with it, we understood our interdependence. We, as HIV researchers and healthcare providers, needed to work with others. Otherwise, just our whole ART rollout is dependent on people having confidence in the healthcare system and having access to it. And so our mutual interdependence became important. What I saw in COVID-19 is that rose to a new level, because, I can only be safe if you are safe, and you are safe only if I'm safe. So now I'm fundamentally dependent on you. Yeah. And we've been very fortunate in that ex-President Nelson Mandela imbued in our nation the fundamental concept that exists in our African culture, which is referred to by the word Ubuntu. And Ubuntu is really about I am because we are. I am not an island. I exist because we exist together. And I am dependent on you, you are dependent on me. And so that concept has really been fundamental to the way in which we've had to respond, is appreciating our mutual interdependence and exploiting that ability to work with each other. Thank you.
Well, thank you, Slim. And we've seen marvelous examples of that in the US. And unfortunately, we've also seen quite the opposite, where people were politicized in their responses. They were divided by misinformation and disinformation. And we ended up in a struggle between the public good and some kind of notion of private liberty that has really been challenging for us as a country and continues to be. And we see this also in the vaccine hesitancy issues, that vaccine hesitancy actually has a political orientation. It has a race ethnicity component that is going to be a very big challenge for us to overcome. And I think the vaccines as a public health tool really underscore the Ubuntu of this. And I would just say that it really underscores it globally. If we make the decision that it's okay for so many countries not to have vaccines for years, we will not get ahead of this virus.
Sorry, Chris.
Go ahead, Eric, go ahead.
I was just gonna Slim really eloquently, I think, presented in his third point the commonality of the human response. HIV taught those who were in front of it for years that there's only so many ways human beings respond to crisis. And you see the elements of that understanding and then pivot into reaction has different slopes of ascent. HIV had a very flat slope. I mean, 10-year incubation period, everything was in slow motion. Our thinking of how the virus moved through the population was incremental over years, and the group here was really focal in describing that. But the galloping light speed of COVID, as Slim pointed out, put us in a moment where the lack of decisions became reflected as mistakes, as opposed to proactively making decisions and seeing the response and molding it and making and refining it so it's better. COVID was so quick that we had to eat the decision and the ramifications of it, and then go on to the next challenge before we had solved and understood completely how to solve the first wave. That accelerated picture of infection and spread, response, understanding, refinement of program, and coming back to contain the movement of the virus was the challenge in every municipality in the United States and globally. And I want to underline the moment that we have, because of what COVID has revealed to political systems, delivery systems, and to populations, is the idea of Ubuntu. And if we cannot take advantage of this global kind of awakening of this is a common threat, we need to orchestrate an answer that includes everybody on the planet, we have truly missed an opportunity. It's my hope that the Biden administration with our multilateral colleagues can pivot this discussion into a shared responsibility discussion where we acknowledge the differences that we see and have seen again with COVID. We acknowledge that those reflect disparities that have been there for hypertension, diabetes, and coronary artery disease, and you name it, forever. And that now, understanding the connection that COVID has presented to us and the final common pathway of congestion in our hospital delivery systems that hurts us and amplifies the hurt in the population. I believe we will have missed a remarkable opportunity to bring the planet together. The Biden administration sees this as a glimmer down a tube. There's so many things coming at them that they haven't prioritized this particular issue where I feel they should. But I believe it's just a matter of time, out of urgency or out of anticipating a expanding need that, if engaged now, will be smaller. The vaccine effort is that moment where we should converge, show real leadership, not have anybody on the planet left out of it, and at least make every effort to close those gaps. But it comes from a transparency of revealing that there are those gaps, and we need to acknowledge and respond to that. So I really wanted to reinforce Slim's point.
Chris, may I build on those 2 points, and just to say, I'm sure everyone on this call, I remember the moment when we realized ART was going to transform HIV. I remember the exact data sheet. I remember exactly what I saw. I'm like, everything's going to be different, but it can't just be different for people in the US or people, it has to be different for all. And all of us have fought for that. Exactly the same moment for COVID. And everything, so I love this, everything happens fast. The pace of the vaccine development, just truly, truly remarkable. We can't forget that, and must have a global society that anticipates pandemics, is ready to go, has the factories ready to manufacture new vaccines when these pandemics come about. But then going down to the very community level, when we think about access, I just want to make the point in here in San Francisco, all the resources we have, and when we talk to the most affected populations and all the plans were being made to vaccinate people in brick and mortar places, 50% of the people said they didn't have a doctor, they didn't have a health system. These are the people who most needed to get these vaccines. And so I think, once again, we just have to be thinking about the macro global and going right down to the community level and make sure our plan is comprehensive.
Yeah.
Perhaps I'll just make a short point on what both Eric and Diane have so eloquently touched on. That was an issue that came to me very early on when the minister asked me to serve in this committee to advise government. We understood that when we were making, for example, at the beginning of April last year, so it's over a year ago, on flimsy evidence, really, and actually contradictory evidence, we recommended that South Africans should wear a mask. This was at a time, it was 2 months before the WHO made that recommendation. And the evidence was not clear. So in the midst of uncertainty, there has to be an element of trust. That element of trust is built out of mutual respect. The moment you lose that mutual respect, you lose that trust. Because you're asking somebody to wear a mask on the basis of what you think is in everyone's best interest. And especially because we were telling them to wear a mask, not for their own benefit, but we were telling them to wear a mask because it protected others. So to do that, because once you lose that trust, then basically you're in a situation of conflict. And if you sow that discord, if you bring into that kind of equation anything that challenges and undermines that trust, you are undermining the ability of us at a local level, at a country level, at a global level to deal with this pandemic.
Absolutely.
Salim, you remind me, the other aspect of that is that in our culture, we have moved to I don't know how to describe it, but kind of a gotcha mentality where from every newspaper interview, every interview on television, they're actually aggressively trying to find something that they can put a hook on that says you did something wrong or you didn't know or and I have to say that really has had an impact on everything. And I'm just becoming aware of how it's continuing to ripple. We were focused on the Trump administration's kind of loudness with that, but it permeates in a way that is beyond the Trump moment, the Trump administration moment. And I think it's something that we as a profession and as global health, those engaged in global health need to start bringing these more social agendas into the thinking of the science and of the response, because it's going to give us a better, stronger, more resilient one. And I believe with special populations will become critical to achieve the access and retention goals that we've got. So I really think that's important too.
Yeah, we have a question from the audience, from an attendee that I think is a rich one, and I'd love any or all of you to think about it. As the major viral crises don't touch me personally, I don't have a way of using them to calm my fear about COVID never being over. Is AIDS over? And what have we learned about how to live with the seeming possibility of never over for this worldwide pandemic? I think you hear in that the concern concern, fear, the anxiety about achieving control of COVID, but also this question about, is HIV over? Can we declare victory? And Diane.
As someone who comes from the continent that has 70% of the epidemic in the world, I think we have seen how, with all our best intentions, we had hoped that we would achieve a target of 500,000 new cases only in 2020. That's a target we set some 7 years ago.
Yeah.
Unfortunately, there were 1.7 million new infections last year. And in fact, if you look at the way in which the number of new infections, the trends in that, it's more or less stalled or slowed down to snail's pace in terms of its decline. So we're not anywhere near the end of this epidemic or pandemic of HIV. If anything, it needs some kind of serious boost if we are to really make a difference. I'll stop there because Eric and Diane know this area even better than I.
No, certainly, Salim. You're absolutely. I mean, AIDS is not over. I think that the intersection with our COVID pandemic is that the new cases are disproportionately affecting vulnerable populations. And that is an area that Chris is just the global scholar on and has written about. And that's globally, that's in the United States, plateauing. In San Francisco, we've seen declines, but we still have hundreds of cases. This is a completely preventable disease. And we in San Francisco still have hundreds of cases. And the people most affected are those who are, the health system has, in my opinion, and our efforts have failed to meet them where they are at. Now, HIV is a chronic disease. 38 million people, as Salim said, are living with this disease. SARS-CoV-2, COVID, is not a chronic disease. It is a disease that people get. They can have long-standing complications from this disease, of which is a rapidly evolving field that we are learning about. But we have had pandemics of SARS viruses that have come and gone. And I think we could speculate, and probably no one knows what is going to be the future of this pandemic. There's multiple infectious disease pandemics all over the globe. I hope you are reassured just in this panel and discussions that we are having that there is definite hope that with the next pandemic, that we will do it better next time, that certainly COVID is not over, and we are all committed to contain and overcome this pandemic in the best way we can, that ensures rights of all people in the process, both their lives and their livelihoods. And I also, respect is such an important word. When we talk about how we go forward, I would say humility. We all have humility in what we know, what we don't know, and the path ahead of us to do it better. So those are just comments I wanted to share.
Yeah. Eric, I don't know if you want to respond.
I think that you've really said it beautifully. No, HIV is not over, and we now have different opportunities with HIV positive people that we need to position our delivery systems to deliver to them. And that evolving, ever-changing interface, being aware of the issues of access and retention is what it gets down to, as continuously trying to understand that, because it changes. But I think what COVID really showed us, and we've said it already, is the inability of the delivery system to respond effectively with an equitable kind of playing field to all populations, the ability to respond to the threat. And I hope we look at this and absorb the lessons that it delivers to us to fix, to accept the inequities in how we're able to identify, enter, and retain people, and to incorporate that in our strategy for moving forward to strengthen all of those relationships. I believe that this is going to be an ongoing fight. It's not going to be a let's talk about it, get it done. Each generation that grows up as those who utilize services and those who serve in those delivery systems as providers need to understand that this connection to the community is vital to your ability as a delivery system to be relevant and anticipate the needs of that population, as opposed to, as Slim was saying, Diane, responding and trying to get a proactive lean into pandemic identification and response. And it all gets down to anticipating the need, putting the systems up to gather the information and analyze the information, not just collect it, so we can be proactive. So I think those lessons are all over the COVID events, and I hope we can learn them.
Yeah. I guess I would just take the chair's prerogative and also add that that there are lessons learned from the COVID experience as we go through it that really may have very important impacts and positive impacts in the HIV response. And just to give one example, the two vaccines that we're currently using in the US that have emergency use authorization both use this messenger RNA technology. That's the Moderna and the Pfizer vaccines. Both of those vaccines are based on technology that was invested in over decades, really, by multiple groups developing that technology. And it turned out, fortunately, that it was able to be used rapidly for the development of these vaccines. There is now early data from an early phase study using that messenger RNA technology to try and develop an HIV vaccine. And the early immunogenicity data is very compelling and exciting. So, so that may be really an important benefit. All of us in one way or another have been involved in HIV vaccine trials over the years. In my first job in 1992, and we were supposed to be 2 years away from an efficacy trial. I've kind of been chasing 2 years for 3 decades. Of course, we're still not there, but there really is hope in science. I guess I would also add that as a young member of my team put it, hashtag not our first pandemic. That SARS has really highlighted that AIDS is not over, and that we really need, as all of you have reiterated, such a more robust global engagement and dealing with pandemics. And that, of course, has to be grounded in respect, in trust, and in equity. And I think I would say that the huge public health and human rights challenge ahead for us really is trying to see these COVID vaccines as global public goods and trying to ensure global access for everyone. We're going to need 7 billion people immunized to get out of this. We did it with smallpox, the height of the Cold War. We can do it again, and we have to. And with that, I want to thank all of you so much. I'm going to invite Donna McKay, the PHR director, to come back. I just want to say I think this has been an extraordinary, rich conversation. And my takeaway is that the underlying theme of the next phase of the COVID response and the global vaccine rollout has to be Ubuntu. We're all in this together. And we really need that global human solidarity. Donna?
Chris, thank you so much. Thanks to the incredible discussion today and the panelists. It was so rich, and we could have gone on for much, much more time. You touched on so many important dimensions, including many human rights implications of this pandemic, and each one is so critical and follows such an important thread. The insights that the 4 of you have from your decades of leadership in the global HIV and AIDS epidemic is so relevant to this work today. So thank you for helping us to see those connections and highlighting the many lessons that we've learned, areas for opportunities for combating this massive pandemic, and Diane, as you said, for the future as well. And thank you also for reminding us that we are at the same time experiencing partnerships and collaborations in science and in the health community like never before. And so thank you for your leadership in that regard, and for being with us today. And I hope that you'll come back and continue to have conversations with us. For those who are joining us today, we will share this webinar on our website and on social media, and we hope that you will share it with others who will have an opportunity to listen to it and take action. So thank you so much for today, and we're really grateful for your service and your work.
Well, thank you, Donna. Thanks, everybody.
Thank you.
Thanks, everyone.
Bye.